Assalamu alaikum. Bismillahirrahmanirrahim. I am Dr. Alishba Rasool, PGR Community Medicine, and today I will be presenting Geriatrics under the kind supervision of Professor Dr. Saira Afzal. You do not heal old age, you protect it, you promote it, you extend it. The learning outlines of this presentation are introduction, characteristics and issues of elderly people, comprehensive geriatric services, prevention of diseases of elderly, WHO goal for elderly, age-friendly cities, recent advances, and MCQs. The learning outcomes. At the end of the presentation, participants would be able to know the diseases of elderly and their prevention, comprehensive services, and WHO goals for elderly, recent advances, and they would be able to answer the MCQ session. Introduction. Health of the elderly is dealt under geriatrics. It is the practice of medicine in its preventive, curative, or rehabilitative models in the elderly. Geriatrics, the care of the elderly, differs from gerontology, which is the study of aging process itself. It can be applied in relation to many healthcare contexts: geriatric nursing, geriatric psychiatry, or geriatric rehabilitation. Pakistan's aging population and epidemiology of geriatrics. Age distribution of Pakistan is shifting towards the older age group. Number of people over the age of 60 has considerably increased. Today, there is no less than 20 million people in this category, and with the rise in the expectation of life at birth, the number is increasing. With the growing interest of the nation in family planning and consequent lowering of the birth rate, the population pyramid of the future will shrink at the bottom and grow wider at the top. Characteristics of elderly people. Loss of status, insecurity about meeting the demands of life, apprehension about health, difficulty in adjusting from work routine to retirement, inability to find avenues of service that will provide personal satisfaction, difficulty in meeting stress created by social change. Health problems of elderly, loss of confidence, arthritis and rheumatism, disorders of vision and loss of hearing, accidents, diabetes, hypertension, coronary vascular diseases, prostate enlargement, depression, senile dementia, Alzheimer's disease. 1 in 6 older people experience abuse. Psychological 11.6%, financial 6.8%, neglect 4.2%, physical abuse 2.6%, and sexual abuse 0.9%. Integrated services. WHO in 1947 recommended that countries develop integrated health services for older persons, including elements of medical and social prevention, multidisciplinary assessment, home and institutional treatment and management, rehabilitation, long-term care, and supportive social welfare. Social welfare measures include national assistance, supplementary pensions, home services, meals on wheels, old folks' homes, status up service, provision of services of health visitors, public education, Health Committee of Senior Citizens Association, considering elderly care in all health policy. Comprehensive geriatric services. Health needs of older people are complex and their care should be provided through multidisciplinary systems as described. Community care, hospital care, primary care, institutional continuing care, and education. Community care. Primary care by GPs, community nurses, home visits, meals on wheels. Care at home, rehabilitation, translational care decrease the load on acute hospital service. Long-term care. Majority of older people will not live in institutions but will require some form of long-term care during the course of their life. Now there is a trend towards care being increasingly provided in community settings. Informal care and social support can be physically and emotionally stressful for caregivers. We must cater the needs of informal carers in planning and allocating the resources. Hospital care. Services should include hospitals, geriatric evaluation and management units, disease-specific services, specialized units for stroke, diabetes, respiratory disease, and CVS. Institutional continuing care, medical surveillance, avoid treatment transfer to the hospital, multidisciplinary rehabilitation, maintenance of function, social, and recreational activities. Education, departments of geriatric medicine, PG training, train professional and non-professional health workers. Prevention of the diseases of elderly, primary, secondary, and tertiary. Primary prevention, healthy habits, immunization, influenza and pneumovax, iatrogenesis prevention, medication review, control lipids, hypertension and glucose control, prevention of falls, fractures, and osteoporosis, group or home-based exercise, individual risk assessment, home safety assessment and modification, bisphosphonates for bone density, and coronary heart disease. 6 drugs in recommendation, 3 low-dose antihypertensive, 1 statin, aspirin and folic acid could prevent up to 88% of coronary heart disease and 80% of stroke. This therapy has been proposed to all people greater than 55 years of age, regardless of CVS risk. Secondary prevention, screening for hypertension, dental diseases, sensory impairment, medication and side effects. Colorectal cancers, breast cancer, cervical and prostate cancers. Nutritionally induced anemias and depression, urinary incontinence, pediatric problems, TB high risk, syphilis high risk, stroke MI. Tertiary prevention, rehabilitation, physical deficits, cognitive deficits, functional deficits, and caretaker support. Aging. Every person in every country in the world should have the opportunity to live a long and healthy life. Yet the environments in which we live can favor health or be harmful too. Environments are highly influential on our behavior and our exposure to health risks, for example, air pollution or violence. Our access to services, for example, health and social care, and the opportunities that aging brings. The number and proportion of people aged 60 years and older in the population is increasing. In 2019, the number of people aged 60 years and older was 1 billion. This number will increase to 1.4 billion by 2030 and 2.1 billion by 2050. This increase is occurring at an unprecedented pace and will accelerate in coming decades, particularly in developing countries. This historically significant change in the global population requires adaptations to the way societies are structured across all sectors. For example, health and social care, transportation, housing and urban planning. Working to make the world more age-friendly is an essential and urgent part of our changing demographics. WHO goal for elderly active aging. According to the Active Aging, a policy framework by WHO. The process of optimizing opportunities for health, participation, and security to enhance the quality of life as people age. Its goal is that older people remain a resource to their families, communities, and economies. Maintaining autonomy and independence is a key goal. It shifts strategic planning away from a needs-based approach, which assumes that older people are passive targets, to a rigid-based approach that recognizes the rights of people to equality of opportunity and treatment in all aspects of life as they grow older. Healthy aging, process of developing and maintain the functional abilities that enable well-being in the older age. Healthy aging starts at birth with our genetic inheritance. Goal for healthy aging: to build and maintain functional ability, be mobile, build and maintain relationships, contribute. It is achieved in 2 ways: building and maintenance of intrinsic capacity, enabling those with a decrement in their functional ability to do the things that are important to them. Healthy aging is all about enabling older people to enjoy a good quality of life. WHO does this work in line with the Global Strategy and Action Plan on Aging and Health and the related UN Decade of Healthy Aging in the following 4 action areas. Change how we think, feel, and act towards age and aging. Ensure that communities foster the abilities of older people. Deliver person-centered integrated care and primary health services responsive to older people, and provide access to long-term care for older people who need it. Age-friendly cities. The WHO promotes the goal of age-friendly cities that support older people by optimizing opportunities for health, participation, and security. By 2030, two-thirds of the world's population will live in cities, and in these cities, around one-fourth people will be aged 60 years or old. Environments for older people need to consider not only design and physical features, but also the infrastructure, policies, and service provision. Aspects to be addressed include housing, transport, pedestrian safety, safety from violence and crime, opportunities for employment, and social involvement of older people. The age-friendly city model, according to WHO, transportation, housing, outdoor spaces and buildings, community support and health services, communication, information, civic participation, employment, respect, and social inclusion, social participation. The ESAS program interventions for elderly. 5 ESAS homes for elderly will be established and pension for the elderly enrolled in EOPI will be increased. Recent updates. Optimizing medications with Geriatrics 5Ms and age-friendly approach. Polypharmacy is a common problem among older people as they are more likely to have multiple chronic conditions and many experience fragmentation of care among specialists. The Geriatrics 5Ms framework offers a person-centered approach to address polypharmacy and optimize medications, including de-prescribing when appropriate. The elements of the Geriatrics 5Ms, which align with the approach of age-friendly health systems initiative, include consideration of the medications, mind, mobility, multi-complexity, and what matters. Each M domain impacts and is impacted by medications. And learning about the patient's goals through questions guided by the Geriatrics 5M may inform an age-friendly medication optimization plan. While research on this implementation on each of the 5 elements of the Geriatrics 5M shows benefits, further research is needed to study the impact of this framework in clinical practice. Anemia in elderly patients, the impact of hemoglobin cutoff levels on geriatric domains. The primary aim of the study was to evaluate the impact of anemia according to the WHO criteria on cognitive performances, mood, functional, nutritional status, and comorbidities in a population of subjects aged 65 years or older. The secondary aim of the study was to understand if different hemoglobin cutoff levels are associated with the variation of the mentioned domains impairment. We designed a cross-sectional study including subjects aged 65 or more consecutively evaluated in an outpatient setting from July 2013 to December 2019. A sum of 1698 subjects met the inclusion criteria. They were evaluated with MMSE and CDT and GDS, IADL, PPT, and POMA, MNA, and SIRS results. According to WHO criteria, non-anemic patients reported significantly better performance than the anemics in BADL, IADL, PPT, and PUMA, MNA, SIRS, TOT, SIRS ICC, and SIRS ICS. The same tendency has been found by considering the cutoff level in the whole population. The multivariate analysis showed that considering the 12 gram per DL cutoff level, age, SIRS, and gender were significant regressors of anemia, while considering the 13 gram per DL cutoff level, age, or PUMA or SIRS, ICC, and gender were significant regressors of anemia, while the other CGA variables were excluded by the model. Our study showed that anemia negatively impacts on geriatric people's general status, regardless of which hemoglobin cutoff level is considered. It also highlighted that hemoglobin concentrations less than 13 gram per DL, regardless of gender, have an association with the impairment of the effective functional nutritional state as well as an increase in comorbidities. Therefore, it should be persuadable to consider the elderly person anemic if hemoglobin is less than 13, regardless of the gender. Now it's time for our MCQ session. Health needs of older people are complex, and their care should be provided through multidisciplinary systems called comprehensive geriatric services, which include A, institutional continuing care, B, support group, C, emergency services, D, tertiary care, or is it E, ICU care?
B. B.
It's A. The therapy proposed to all people greater than 55 years of age, regardless of serious risk, as a means of primary prevention in two drugs in combination, statin and aspirin. B. Folic acid. C. Calcium, CAC 100. D. Six drugs in combination, three low-dose antihypertensive, one statin, aspirin, and folic acid. Or is it E. Zinc?
B.
It's D. The process of optimizing opportunities for health, participation, and security to enhance quality of life as people age. This policy framework by WHO is called A. Active aging, B. Healthy aging, C. Super aging, D. Age-friendly cities, or is it E. SR's program for the elderly?
B.
It's A. Active aging. Goal for healthy aging is to build and maintain functional ability, be mobile, build and maintain relationships, contribute. It can be achieved by A. Extrinsic capacity building, B. Building intrinsic capacity, C. Healing from within, D. Meditation and yoga, E. Going for a walk.
B.
Yes, B is the right answer. In elderly people, chronic diseases are common. Select from the following which is more responsible for discomfort and disability than others. A. Skin cancer, B. GID, C. Diseases of the heart and blood vessels, D. Disease of the locomotor system, or E. Respiratory illness.
E. C.
It's D. D. Diseases of the locomotor system. Loss of recurrent memory in old people is common. Usually it starts when person is about 65 years old. However, loss of recent memory may start earlier. The early loss of recent memory is known as A. Senile depression, B. Dementia, C. Schizophrenia, D. Senile psychosis, or is it E. Alzheimer's?
Dementia.
It's Alzheimer's, E.
E.
In old age, level of immunity is low and degenerative diseases are common. From the following, choose the one frequently encountered in older people. A. Measles, B. Mumps, C. Rubella, D. Cataract, or is it E. Influenza?
D.
Yes, D is the right
B.
answer. D is the right answer. Senile dementia is a common health problem. Choose the most appropriate regarding this. Starts at young age. B. Deficiency of antioxidants. Can be cured with medicines. D. Tremors. E. Main feature is forgetfulness.
E.
Yes, E is the right answer. Populations of old people are increasing in the world. This is mainly due to better health facilities resulting in increase in life expectancy. From the following, choose the most appropriate statement regarding old people. Accidents at home are more common as compared to outdoor. Larger doses of medicine required to treat them. The number is decreasing in developing countries. Cognitive abilities increase. Consume about 5% of the health expenditure.
E.
No, it's A. Accidents at home are more common as compared to outdoor accidents. An old person seeks immunization against the infectious diseases. Out of the following, choose the most appropriate immunization for this purpose. Person, A. Mpox, B. Chickenpox, C. Influenza, D. Diphtheria, or is it ETB?
C.
Yes, it's C. Influenza. This is the key of my MCQs. Please like and share and subscribe to our YouTube channel. Thank you.
Thank you very much, Dr. Alishba. Very nice presentation. And the most important topic in public health, community medicine, as well as in preventive medicine is about the geriatric population, because very less work has been done in this part of world and a lot of work has yet to be done. I am more happy about this that Dr. Alishba is going to present the Department of Community Medicine at Aga Khan University, and I have lot of best wishes and regards for you, and have safe travels. Allah Hafiz, everyone. See you tomorrow, inshallah.
Allah Hafiz, madam.
At
Thank you
9
so much.
a.m., we would have a meeting about the important assignments and the research work that is being done in the past 6 months, as well as the way forward. So, everyone, please make sure at 9 a.m., Dean's Office, Makbul Block, you all should be there. Thank you. Allah Hafiz.
Allah Hafiz, madam.
Allah Hafiz.